Okay, I'm here today with Professor Colin Morley, who's probably known to many of you, but I'm just going to go over his biography briefly before we begin. Professor Colin Morley was educated at the University of Cambridge and undertook his paediatric training at the University of Manchester. He was a Nuffield Research Fellow in Oxford, where he started work on surfactant treatment for premature babies. This is extremely important. I'll just mention briefly. We've discussed surfactant previously. It's a lung lining substance that assists with the respiratory system of neonates and helps prevent lung collapse. I believe I'm right in saying that it's had a big impact on the survival rate of young infants. We actually discussed previously that President Kennedy in 1963, one of his children died at a very, very young age, and they weren't even that sufficiently premature. They weren't hugely premature, but if they had surfactant, they probably would have survived. Professor Morley was appointed a university lecturer consultant paediatrician in Cambridge in 1979. In May 1998, he was appointed professor and director of neonatal medicine at the Royal Women's Hospital and the Royal Children's Hospital, Melbourne. He's now a lecturer at the University of Cambridge. Professor Morley has published over 300 papers, of which 90 are related to neonatal resuscitation. And I know that he's still doing research on neonatology because he mentioned some research he's been working on to me recently. So, with that being said, thank you very much for joining us, and hello.
Hello, thank you. Thank you for that introduction and my background. You were going to ask me one question: why did I choose neonatology as a career?
Yes.
I mean, I did as a young doctor, I did adult medicine and adult surgery. I nearly wanted to become a surgeon. I like that side of it, but it was very crude, and I thought I can't be doing this. Now it's improved a lot, as with other things.
Okay.
Um, I liked the children and the babies. In fact,
Yes.
even before I was a medical student, I was fascinated by little babies and their development and how they responded to the world. So I've been very lucky. I've had a good career, worked hard, and by good fortune, I got into research, and
Yeah.
I've enjoyed that.
So one thing I've spoken to Michelle Warden about, who was a neonatal nurse practitioner, was how small the neonates are. Now, I know the gestational period of these infants, and I know the weight of these infants, and Michelle has explained this to me, but I still find it very difficult to imagine such a small baby. So perhaps you could tell me a little bit about that.
Yes, I should have. I've got various mannequins that we use
Mm.
for resuscitation training, and one is meant to be about 700 gram baby, so really very small. And you know that from my wrist to the top of my hand would be about the length of some of those very premature babies. And I've been fortunate and interested in being involved in neonatal intensive care right from the beginning. And I was told, oh, don't resuscitate any baby who's born less than 28 weeks. They just only survive to be handicapped. And, we've got better. That was one of the sort of research things I was interested in. There was respiratory treatment and various aspects of caring for these very tiny babies. And it's got better and better. And now resuscitating a 23-week baby, and they're, you know, 700 grams, skin very thin and transparent, and need support for all their physiological things. So
Mm.
feeding, breathing, and everything. And all the time we're getting better at it.
Yeah, would it be fair to say that this is one of the major advances in medical care over recent decades?
I think that it's like many things. I mean, in my early days, I was very involved with children with acute leukemia. 97% of them died in a few months. Now, 97% survive. That's really good.
Mm.
And many, many things are going to be are improving and will improve with all the modern cell biology and genetics and so on. So I think, yes, been worked through a fascinating time, but now there's going to be even better things coming.
Oh, great. It's good to hear. So we're going to talk a lot about the Lucy Letby case today. So when did you first hear about this, and why was it that you came to question the initial verdict?
Um, I suppose, like many people, I had heard about it, and I've done a number of medical legal cases, and I thought, oh, I wonder what's happening here. But I didn't really take a great interest in it because, well, I was going to say nobody was asking what I thought, but actually, the expert, Chu Lee's expert panel, Chu Lee did ask me to be on that, and I decided, my golly, this is a lot of work. I mean, there's all these babies, thousands of pages of stuff. And if I'm going to do it properly, it's going to take a long time. And I was busy with other things. So I said, well, best of luck to you, but I can't join. And so then there was a statistician who's a good friend of mine rang up and said, what did I know about this case? Because the statisticians are all very up in arms that the statistics that are being quoted is completely wrong and misleading. And so I got a bit more involved then, and I kept up with the literature as best I can. Still read the things that are published, but so yeah, that's how I started.
Hmm.
And I thought that um, I saw some cases. Case of, I think, baby C was one that I saw early on and read through the stuff. That was a baby where it, very tiny baby, 800 grams, I think, um, but and had within about 3 days had bile stain vomiting. Bile stain vomiting is bright green or green, completely green vomit or aspirates up a nasogastric tube. And our studies, we didn't do it in any great detail, but our studies was that if that happened to the baby, it was a potential sign of serious illness. So I thought, and the paediatricians looking after the child rather dismissed it, which I thought was they didn't understand what they were doing. And then there was a case, I think it was baby K, where it was said that Lucy dislodged the endotracheal tube, and paediatrician said was the small babies can't dislodge the tube on their own. Somebody must have done it. And I thought, where have these people been the last few years? I mean, if you work in a nursery, particularly in the early days, um, tubes were coming dislodged all the time.
Yeah.
It was almost a daily occurrence if you worked in a busy nursery that tubes were coming dislodged. So to blame the nurse for it coming dislodged would seem to me completely wrong. And I can go into that in a bit more detail if you want to. So
Yeah.
those are the things that made me think this is a lot of the stuff I was reading, I thought was not accurate, not uh, really the true reflection of the disease. And like many people, I thought, my golly, here's this nurse in prison for life when she almost certainly hasn't done anything.
Absolutely. Very much my thoughts, of course. So we're going to be talking more about child C and child K that you've mentioned as we continue. But firstly, I want to ask you about air embolism. So I know that you've spoken with several experienced neonatologists regarding this injection of air theory that appeared in court. I don't think you can even reasonably describe as a diagnosis. But could you just give me some idea of what the consensus view is on this?
So, of neonatologists like myself who look after all sorts of babies, I ask them, I say, how often have you seen air embolus? Air embolus? I've never seen a case they see. I mean, and then you get into it, and where embolus does or did crop up was open heart surgery, where there was a strong chance that you'd get air into the circulation. But in babies, perhaps we missed some, but I don't think we would have done, but I can't guarantee that. We just didn't see it.
Yeah,
So I think, and this, one of the things I found very frustrating was Dewey Evans, his go-to diagnosis. I mean, it wasn't just an odd case, 1 in 1,000, but virtually, I don't know what it was, eight of the babies. I might not have that number right, but he came to the conclusion they died from air embolus that must have been inflicted, with
yeah,
no evidence that anybody was inflicting things. Um, and he's a smart guy in many ways, in that this was a diagnosis that you can't prove and you can't refute. I mean, you can prove if you think it's happened, like the people on children on heart-lung bypass, where something goes wrong, then air's obviously got into the circulation, and with ultrasound or X-rays, you can see air in the heart and in the big vessels. But if you don't think about it, you don't do that, and so you don't see.
hmm. So one of the things I've been told about this is that he made no effort and no evidence was really presented to demonstrate that the air couldn't have been present accidentally,
No.
which is common. So Professor Arthurs, for example, did this study that's in the court case and it's referenced in the Court of Appeal judgment, in which he found that it wasn't the majority, but it was about 35 to 40% of infants had air present in the great vessels and in these places that Dewi Evans suggested it had been deliberately introduced. So that's a fundamental. Do you agree that's a kind of a fundamental failing of the
Yes,
evidence?
I do. And if Professor Arthur says that's what they found, but of course, and as you said there, it doesn't mean that that was done deliberately. And many of these babies, I've been reading through some of the notes again, they had lots of things done to try and resuscitate them. And it would have been easy for air to get into the circulation. So just because you find it, it does not mean to say that it's been done on purpose.
Yeah, and of course, usually it wouldn't be.
No,
It
it
usually
wouldn't
wouldn't
be.
be. So yeah,
Every neonatal nurse putting things into drips and connecting up fluid is very careful to get rid of the air bubbles and that sort of thing.
yeah,
But during resuscitation, people vigorously hand ventilating these babies. I think it's very easy to blow some gas into the wrong place.
yeah, and of course we should add as well that air can be present and it's not life-threatening at all.
No, absolutely. I mean, you need quite a lot to really stop the heart, which is what's got to happen. So you've got to have enough to fill up the heart and the great vessels, because the heart initially will be pumping some of it round. So, I mean, let's just take this. The circulating blood volume of a small baby is roughly 90 mils per kilo. So if you've got a 1 kilo baby, you would probably need 40 or 50 mils to really uh, cause enough trouble. And if you just put in 5 or 10 mils, I doubt whether it would cause any problem at all. Because as long as the heart's beating, it's going to get moved on.
Yeah. So something that nurses have said to me is that I mean you've just said you need to have a significant amount of air, but they also said with the 10 milliliter syringe that you've got, actually getting all the air obviously we don't believe that Lucy has done this deliberately, but even if someone set out to do this deliberately, the actual mechanism of getting enough air into the infant is quite difficult to do. Would you agree with that?
I would. I think it's, well, there's two sides to that. There's the volume. It's difficult to cut through a fine catheter and syringe to push in enough volume in the time that you're going to do it secretly and nobody's going to see you. And the also the resistance through the tube. They're very fine tubes, and the longer you've got the tube, the more resistance there is. And then, of course, if you actually do inject some air, then if you don't want to be found out, you've got to then replace that with the fluid that's being infused. I mean, I think I can't really imagine how easy that would be to do and get away with it.
Yeah, that's great. So one thing I'll just add as well is that he mentioned 8 babies. So it's important to note that it's not just the deaths where the injection of air was alleged. It's most one. There's quite a few cases where there was one collapse, the infant recovered and was fine. Almost always, injection of air is the accusation there. So I think, and then there's other infants where Lucy was found not guilty, and I believe he threw air in there. And even here in the Court of Appeal, it says child G, the mechanism is overfeeding with milk, but he threw air in there as well. So I think there's at least 12 cases, 12 infants where it's alleged. So it really was the central accusation of the prosecution, basically. Um, so it's obviously very useful for us to know how unlikely it is. Um,
I mean,
uh,
according to one of the things I read, he was asked, "Have you ever seen a case?" And the
yeah,
answer is no.
yeah, that's
And
true.
he's sorry to put it this way, but he's just bullshitting. I mean, he was just making it all up,
Yeah, I'm glad.
and had got a way of talking to the jury and the lawyers that he was just confident that he got it right. Just believe me, I'm right. When he was certainly nowhere near right.
Yeah, so that leads me neatly onto my next question. So in court, Dr. Evans claimed that he had diagnosed their embolism before he was made aware of the x-rays and before rashes or discoloration had been noted. He claimed that he made his diagnosis purely on the basis of babies collapsing suddenly and failing to respond to resuscitation. He has explicitly stated this. So we already know air embolism is an unlikely diagnosis to make in the first place. Then he claimed that he did a diagnosis of exclusion. I mean, frankly, what he said is a joke. I mean, I've already torn it to pieces in a previous video, but I mean, I'd just like to hear your comment.
Well,
Claiming that the diagnosis made on the basis of collapsing suddenly and failing to respond to resuscitation. I mean, could you comment on that?
sudden collapse in these babies, particularly premature babies, and there was a high proportion were premature, is something we see all the time. It's called apnea of prematurity.
Yeah,
They can be going along quite well, and then alarms ring off. The baby's not breathing, its heart rate and oxygen saturation are going down, and the nurses just get used to it, and they turn up the oxygen or give them a little bit of bagging, as they say, and so but he never, I couldn't find anywhere where he'd admitted that it might be apnea of prematurity, which is really the most likely cause for a tiny baby, particularly a sick baby, to suddenly collapse, as they say, suddenly go apneic, bradycardic to go with it because there's not enough oxygen going around. And most of them get better on their own and with a bit of help. But that doesn't isn't on his list. He was a great one for saying, I've been through everything, but that didn't seem to be high on his list differential diagnosis at all.
well, I don't think he did one, to be honest. I mean, I can't see any evidence he did because if you have just the baby's collapsed suddenly, it didn't respond to resuscitation. I mean, my research indicates that there are dozens of conditions for which this could
Yeah.
apply.
Yes.
And you would agree with that?
Well, and this business of, I mean, the whole, so many of the cases, oh, well, the baby collapsed and couldn't be resuscitated. And resuscitation has been one of my interests and research. And I'm afraid to say that it's not easy to do without good skill and training. And my experience is that quite often people can't ventilate the baby, let alone resuscitate in other ways. I mean, they've got to get a good fit with the mask on the face.
Mm.
Often, and I don't know, there's nothing in the notes about these, but people use a face mask that's too big and it leaks. They don't hold it on properly. There's a special way you've got to hold the mask on and lift the chin up to make sure that you're getting a good seal. And one of the things that's frustrated me for years with resuscitation is there's no measurement of what's happening. It's all people just observing and thinking, oh, well, the chest's moving up and down a bit. And they're not very good at doing that either. So it's difficult. And something we might talk about is,
Mm.
can we expect the doctors at the Countess of Chester to be good at resuscitating babies?
Yeah. So considering, we'll just touch on that briefly now. So considering that we know this was not the most skilled unit, they were having nurses, lots of part-time nurses, lots of bank staff, not a lot of experience. Like Lucy was quite prominently involved, even though hadn't been at university for very long. They didn't have a neonatologist on the unit. They've obviously been downgraded. They're still downgraded now. They're still not a level 2 unit. So is it fair to say they might have struggled with resuscitation or they might have found it harder?
I think it would be honest to say, I mean, imagine you're one of the younger doctors who often rotate through the neonates just for 6 months. The number of babies who would need full-on resuscitation in that time would be small. And when, if you're only on duty for 40 or 45 hours a week, the chance of you getting hands-on experience in more than one or two is small. Um, and in my day, we were in the nursery almost 24 hours a day. There was a lot of mayhem going on, and we got a lot of experience. And also, we were there for probably 2 or 3 years. So I think it's a big problem. The youngsters, if I can call these doctors that, are just not in a position to get the experience.
Yeah, absolutely. So another thing, so recently Dr. Evans has done this interview with the BBC Panorama, and he denied he denied numerous times that he changed his diagnosis on child C. And then in this documentary, he says, oh, well, I decided it was inflicted harm. And then it doesn't matter which one of two diagnoses that he made, which one is injection of air into stomach, one's his venous injection. And as far as I understand it, these two different methods would result in a notably different clinical presentation. So would you like to comment on this further?
Yes, I mean, well, air embolus, as we've already said, is rare, and most of us don't get any experience of it at all. So, to know what's really happening, this business of, well, the baby goes blotchy and there's a rash. Well, as babies getting sick and their circulation is poor and their oxygenation is poor, they often go blotchy.
Hmm.
I mean, it's not specific to air embolus. And he put a lot of weight on all the rash and so on. And I see Shu Li is saying that that's not to be relied on at all. So air embolus, if it is going to be an effective way of murdering somebody, you'd have to put in enough air that they would collapse and die. quickly.
Yeah.
Whereas putting air into the stomach, and I don't believe that that's a real possibility, but putting air into the stomach, it would slowly cause troubles. It wouldn't cause, it would slowly interfere with breathing, is what Dewey Evans says. And it would not be, most of them would not die from it.
Mm,
So,
absolutely. But I mean, do you think it as well? Obviously, he's now changed his tune on this case several times, even changing his view in court, he's changing his view after court. I mean, I just view that as farcical. To me, that makes him fundamentally unreliable.
well, I
How do you
think
feel
I'm
about
amazed that the lawyers have even accepted that he, can send in new reports, changing his mind and changing what's happening. I mean, that's, I thought, not the way things should go. He should be, his opinion should be right there. Um, and of course, on the science of the thing and opinions, frustratingly, there was no good neonatologist chosen, or no neonatologist chosen for the defence.
it?
We've seen from Shuli's panel that they weren't all neonatologists, but that, you know, there are good people around. It is said that they won't stand up and give an opinion. I don't actually believe that. On the whole, neonatologists are people who like to see things done properly and babies cared for properly. And that's one of the reasons I'm speaking up about it. I don't care if anybody sends me rude messages. I just got to do the best for the babies on this case as I can.
Yeah, that's great. So while we're on this topic, I think most people that are watching this, it's becoming more commonly known that getting good expert evidence in court is not happening or it's difficult. So, but you say that neonatologists will be happy to speak. I mean, I only desperately wish that had happened because I think this would have been thrown out very quickly. So, what do you think could be done to get better expert evidence in court? I know it's a difficult question, but
Well, no, I think it brings up the whole question of who is an expert.
mm,
And at the moment, if you put up your hand, I'm an expert, and I've worked in this field for a number of years, then that's just accepted. And we've seen, I mean, I was involved in a whole number of cases in the past with, oh golly, Munchausen by proxy man. I can't forget names.
Roy Meadow, was it?
Hmm?
It's not Roy Meadow, is it?
Well, Roy Meadow was one of them, yes, and David Southall.
Okay.
And he was one, I mean, I think I can see that Dewey Evans has always almost modeled himself. David Southall knew that mothers were suffocating their babies. And he was the expert. He wasn't going to be swayed in any different direction. Um, so would people join? Well, I think they should. I mean, I'm not in a position to say whether they will or should, but I think it's rather sad if they won't.
Yeah, absolutely. So I know, so you've accounted David Southall and Meadow. Do you kind of see parallels between them and Dr. Evans? Do you think that's a fair comment?
Much more Southall because he was predominantly in this, and and Roy Meadow. I mean, they wrote a paper. I think Roy Meadow actually was the main author, saying that the following are diagnostic features of Munchausen by proxy or mothers suffocating their babies. And I mean, I went through them all. I wrote a letter to the BMJ saying none of these can be considered to be good pointers to this. There's no statistics, no sensitivity, no specificity, no positive predictive value. They're just ideas. And one of their key things was, oh, you have to be careful of mothers who get very friendly with the doctors. Well, that any sensible mother is quite friendly with the doctors, and to say that they're, it's a pointer to them doing nasty things because they're very keen for their child to get proper treatment. But anyway, I
Which
can go
strikes
on for
me, it
hours.
strikes me as just an idiotic remark, frankly.
It is, yes.
I mean, I find it incredible. Like the criminal justice system just seems to be obsessed with these like specious, circumstantial arguments about things.
Yes.
You know, if you're gonna put someone away for damaging their own infant, that should whether not what their relationship with a doctor or these stupid things that they bring up. What does that have to do with anything? There should be a clear clinical picture. That's it. Nothing else. That's irrelevant. Okay, they bought a birthday card. Like in Lucy's case, they're saying, "Oh, look, she took a photograph of a thank you card." Yeah. So what? What does that have to do with anything? I
Yeah.
just find it insulting,
Yeah.
frankly.
It's, I don't know. I mean, particularly the Munchausen and now this induced injury or whatever they call it, inflicted injury.
Shaken
Um,
baby syndrome, do you mean?
well done.
Yeah.
um, it's just, I mean, of course, there are cases out there, and I've been involved in cases of
Mm.
mothers who were doing harm to their children. But there are a lot of people whose children have got significant medical issues that the doctors don't diagnose properly, and then they blame the mothers.
It's scary. I mean, I explained to my friend, your children are old enough now, this is probably not going to affect you, but your child can die overnight, could be a cot death or something like that. And then all of a sudden, all it takes is one doctor to say, I think this mother has shaken
Yeah,
the child, and you're not being counseled, you're in a police station. Um, and that's pretty scary, I think,
that
when
must be terrible, absolutely terrible. Well, I was very interested in cot deaths. We wrote papers about that, and in fact, you know, again, the idea was these children have died suddenly and unexpectedly. But if you went into it, not all by any means, but a lot, had significant symptoms of illness in the hours beforehand. It was so if you knew what to look for or think about, um, and you know, so
hmm.
anyway, we could go on talking
Yeah,
about
yeah.
these
Well,
things
we
for
could just
hours.
talk about shaken baby syndrome for 2 hours, but let's move on with what we're going to discuss as well. So we want to talk about this gaseous distension of the stomach.
Yes.
So how likely do you consider that to be? This was something that appeared in Lucy's case.
Well, I don't think gaseous distension of the stomach would be likely to kill a baby. I mean, again, Dewey Evans has come over very strongly. Oh, it splints the diaphragm, stops the baby breathing, and suffocates it. I don't know where he gets that from. I mean, first of all, the stomach, although it's a balloon, as it were, there's the esophagus, and we all burp, babies burp, and if you've got extra pressure in there, it's going to come up the esophagus. It's not going to just blow up and up and up to stop the diaphragm. And, people have talked about gastric distension from CPAP.
Hmm.
And yes, some babies on the CPAP get a bit of gastric distension, but most of them don't. We don't really know why some do and some don't. But I don't think, in my quick look at the literature, there's any cases of babies who've been died from having their stomach inflated during CPAP. So I think saying it's gastric distension, air distension of the stomach is a wild hypothesis that is not really logical.
Yeah. So you touched upon the signs of bowel obstruction in child C, but could you just go over those again, please?
Yeah, well, thank you. So bowel obstruction Okay, right at the beginning, baby starts vomiting green bile, worrying sign. They get a abdominal distension, but it depends whether the obstruction is high. Let's say the obstruction is in the duodenum, then there's no gas in the bowel if there's an obstruction there. And if the obstruction is right low down in the rectum, then you can get a lot of gas in the bowel that isn't able to move on. So distension, bilious vomiting and distension, and of course vomiting anyway, because the bowels aren't working. So yeah, I think
Yeah.
there's a whole number of causes that we all know about. And in this case, the baby, of course, the other sign of obstruction is they don't pass the meconium or pass a stool. So the stuff isn't getting through. And there's a number of causes of that. It might just be a stenosis, a blockage in the bowel. It might be that it's Hirschsprung's disease, where the nerves in the rectum don't work properly. But one of the things that's been published in the last few years, it's not brand new, is that there can be, so the nerves operating the lower bowel just aren't working very well. And it's a sort of functional thing, it's not an anatomical thing. So, yeah, I think. But we won't know in this case. I mean, they certainly did biopsy at post-mortem and showed that there was no Hirschsprung's disease, which they would see on the specimens that they'd looked. But there was no doubt she had bile stain vomiting. She didn't pass meconium and had distension.
Okay, that's great. I'm just going to put my dog out. She's being really annoying.
That's all right.
This case, either come here or go out. Come here. Here. Hey, there we go.
He
She
might.
just if
I've
I'm
seen it. I've seen him before on your videos.
if she's not if I'm talking and I'm not stroking her, she just cries.
Oh,
But then if I put her out, she's like, "Oh, I'm not in the same room as you now." It's not so, but she lies away from me, so I can't reach her. So I just had to move her. So sorry about that minor
no, that's all
technical
right.
issue. Um, yeah, so that's absolutely great. So a very simple question now. Do you think the hospital did an adequate job of managing and treating child C?
No, simply, I mean, they didn't get the diagnosis right. They certainly didn't get, I mean, a child with bilious vomiting who's got distension, no bowel motion, no meconium pass, should have been referred to the surgeons at Alderhay and had proper investigations. Instead, at the Chester, they kept saying, "Oh well, it's all right. It'll be all right tomorrow," sort of thing. And of course, it wasn't.
Yeah, absolutely.
So, did they look after it properly? No, I think they were very sort of. I don't think they really knew what they were dealing with.
Hmm.
They wouldn't. The ordinary paediatrician wouldn't see babies with bowel obstruction more than you know once every couple of 3 years, I would think. And particularly a very premature baby, that just adds to the difficulty.
Hmm.
And often, as far as I can read from the notes, they'd ring up the older hay, and the older hay would say, "We're jolly busy, we haven't got any room. Just keep going, you're doing a good job."
Yeah, yeah, absolutely. So can I ask you about the kind of step up in intensity and demands from going from a level one to a level two unit? And then I think the general consensus is that some of these babies require level three care. I mean, how significant is that?
Oh, well, very significant in that level three care's staffed full time by full time neonatologists, full time, very skilled neonatal nurses. And so and they're proactive. They don't wait and see what happens. They can recognize the signs. We've got to be careful. This baby needs proper investigation and proper proactive management. Um, and so, yeah. Whereas if you work in a smaller unit, you don't get the experience and you don't quite know when to react or even whether you're overreacting. I think it's difficult if you're in a small unit, but did they look after the baby as well as they could have done? I think the answer is no.
Yeah, very common. So we're going to look at child G now as well, briefly. Now I really consider this. I mean, I don't know if you've seen the court
Did you say
cross-examination.
child G or D?
Child G, child G.
G, right?
This is the child that's overfed with milk, allegedly. So I don't know if you've seen the court cross-examination of Dr. Evans on this case, but truly it is comical, frankly. Um, so he has made this assertion that child G was overfed with milk. Do you think there's any basis for that whatsoever?
No. Next question, please. No. I mean, why do I say no? That baby was very tiny, and I'd been at Arrow Park for quite a while and went back to Chester, and then it had an enormous vomit, projectile vomit over the sides of the cot or whatever it was in. And they said this is very rare, so doesn't happen. Um, and one of the things they never mentioned was that within a few hours of that vomit, it had a big loose stool, diarrhea. And the most likely thing was that baby had gastroenteritis, a viral gastroenteritis. It went on vomiting for a while. Um, I think common things are common. I mean, it'd have been in a children's hospital and where there's bugs around, you're vomiting and diarrhea. That is gastroenteritis, and particularly if it settles down. Overfeeding with milk, I don't know that you can overfeed. I mean, you can, if it's got a tube down, then you could keep pouring it in. But I think wouldn't be easy to go on pouring it in and over distend the stomach. So, I mean, again, if I was there, I'd say to Dewey Evans, well, interesting idea. How many patients have you seen who've been overfed?
Yeah,
And the nurses, every baby, there's a chart saying, right, this baby needs so many mils of milk every hour or every 3 hours or whatever. And the nurses would be very careful to make sure that they gave the right amount. I mean, there's one thing about nurses, particularly neonatal nurses, they're obsessional about doing things as well as they possibly can.
yeah, yeah, I agree. Um, so we spoke about the quality of care or lack thereof with child C. So could you speak about some of the other medical mistakes that were made on the unit as you see it?
Well, I think we've already touched on it, and it's one of my things is that it was always said, well, the baby collapsed and it couldn't be resuscitated. And I was saying, well, the doctors couldn't resuscitate it because they weren't doing a good job. And that seems very critical of them, but unfortunately, as I said before, their chance of getting good experience at doing it, and it's becoming rarer. You see, in the past, when babies died, we'd take the poor little body into a side room and practice intubating it and that sort of thing. And we got quite good at that because we could do it on a real person. And not surprisingly, then people said, oh, you can't be doing that to babies. and it was stopped. But of course, it meant that the kickback on that was that people didn't get so much experience.
Mm.
Now there's not so many babies who need full-on resuscitation, so the young doctors and nurses aren't getting the experience, and I think it's a real problem as to how to train them to make sure that they do know what they're doing.
Yeah,
And
because you see these, mannequins, as you mentioned, and
yes,
I'm sure that's illustrative to some extent, but it must be very different from intubating or extub,
well, the standard the standard thing is you're in a resuscitation training course, and you'll get to the stage, you're given a mannequin and a bag and a mask, or it might be a near buff, but with a mask, and just, see if you can make the baby's chest move. And if you do, well done, you pass. What I was doing, and well, the guys who work with me, we recorded a lot of resuscitations to see what was happening. We had physiological recordings of the tidal volume and the ventilation, and we had videos of what was happening. And only then can you really see the mistakes that are being made. It's still one of the most difficult parts of neonatal medicine, and there is no measurement at all. Although the stuff's there, we made it and showed it, but nobody seems keen at the moment. Well, they're beginning to start making resuscitation monitors so that the staff can see.
yes, I'm careful myself about being critical of errors made in a hospital because I've never worked in a hospital and it's a pressurized situation. But my reflection, having read the report and having spoken to nurses and doctors, is that yes, mistakes are made with diagnosis and so on, but I understand that can be subtle and there can be subtle signs and errors can occur. But it seems to me on the unit that some of the fundamental physical processes that you would be required to carry out, they just weren't very good at, or they were failing fundamentally at. And I spoke to a nurse, for example, and there's this incident that you may or may not know about where Lucy's at a salsa class and they send her a message asking her to do some procedure. And the nurse told me this is relatively simple, like that they should just know how to do this. So do you think it's like a fair comment to say they were struggling with some of the physical processes on the unit?
Absolutely. I mean, and some of the things they were trying to do, I mean, a baby would collapse, they'd be struggling to intubate it, they'd try intubating several times, they mainly using bag and mask, and they give lots of adrenaline. 6 doses, 8 doses of adrenaline. I mean, I never heard of that before. Perhaps I'm out of date, but the key fundamental thing with resuscitating babies, on the whole, 9 out of 10, or will have a normal heart. And what the heart needs is oxygen. And if you get the ventilation going, and usually the heart is beating a bit, they will pick up very quickly. And one of the main reasons for not being able to resuscitate babies is that they're not ventilating them properly. Maybe they've got a leak at the mask, they're not getting enough tidal volume in, all sorts of things. But you only know, it's like many other things. And in the nursery, they should be having babies on ventilators these days that are measuring what's happening. So, um, anyway, I've forgotten your question.
No, no, just about whether they were good at physical processes. So
Not good at all.
yes,
Um,
I mean that seems very clear. But I mean I always try to be very balanced in what I say because at the end of the day, they're dealing with life and death situations, very vulnerable
yeah,
infants. There's pressure. I understand that. So I do try to be fair. But when you see things like 6, 7 attempts to do one intubation, and that doesn't sound good.
no, no. Well, that is getting better. Now there's video laryngoscopes. So the person who's training or supervising them should be able to see on a screen what the trainee doctor is seeing down the throat. And it's very, you just move a little bit left, bit up, bit down, keep going. You're not quite far enough, or you've gone too far. And so having a video for somebody, your instructor, to look at with you is very helpful.
Yeah, yeah. Um, so Dr. Evans has made these comments, specifically said this in court, I believe, that resuscitation efforts made on the unit were excellent. So would you like to comment on that?
They weren't. I mean, well, okay, one of the problems I've had, and I think is that I've never been able to see any of the notes of
Hmm.
and what they were doing. I've
Yeah.
no idea what equipment they were using really. I've no idea what pressures and rates and everything that they were using. And so there was this sort of blind faith that the doctors who are trying to resuscitate a baby, if they can't, it's not their fault, it's the baby's fault. Um, and so I think that, yeah,
Yeah.
probably said enough about that.
Yeah, yeah, that's clear. So another claim that's been made by Dr. Evans in an Australian documentary was that the infants in the case, in the indictment, weren't really experiencing any significant breathing difficulties and didn't really require any oxygen. How do you feel about that claim?
Well, I mean, there's absolutely nonsense. If you go through, I mean, just the court transcripts and other things that are available, they're always saying that babies were grunting, the babies had indrawing, the babies were not breathing adequately, and they quite rightly were giving them oxygen and CPAP.
Hmm.
Um, if it'd been me there, I would have turned the CPAP pressure up, but we don't know what pressure they were using. There's good evidence now that we should be using higher pressures to get the lungs aerated and get more oxygen into the baby. So I think, no, they certainly, most of them had breathing problems of one sort or another.
Oh, can I just ask you about the CPAP thing then? Because I've not heard this before. So, in simple terms, can you explain why you might use higher levels?
Okay, so CPAP, okay, let's just go back to the beginning. The
Okay.
babies in utero actually give themselves CPAP. Babies in utero breathe, okay, but they are very clever. They use their larynx to keep their larynx closed a lot of the time. And so they're making breathing movements. And because the larynx is closed, there is an increased pressure in the lungs. If they don't have a larynx, so you do animal experiments on lambs and fetal lambs, and you put in a hole in the trachea, then their lungs don't develop. You need a positive pressure. CPAP is really just giving a positive pressure to the lungs after they're born in order to help hold them open. Surfactant, mature surfactant in term babies or you and I, one of its main jobs is to stop the lungs collapsing. It holds it open. It's got special property to hold the lungs open. Um, but if they're premature babies and they haven't got very good surfactant and various things, it's good to give them some positive pressure to help hold the lungs open. The standard thing, which is based on no evidence whatsoever, is to give them 5 centimeters of CPAP. Some people even say 4. And I say, oh, but what about 6 or 8 or even 10? Uh, and people have been very reluctant to put the pressures up. And I say, but the oxygen's bad. You need to make sure the lungs are getting open as well as they can. And let's just put the pressure up. And there's a study or two just come out showing higher pressures, they get better oxygenation. So it's like so many things, it's fluid and it's changing, but and CPAP is absolutely one of the best things that we can do for babies with breathing problems. You see that you will have heard and read that they say, oh, the baby's grunting after birth. Okay, grunting is the baby shutting its larynx and squeezing the lungs, the chest, and then because they've got to breathe, so they then have to breathe out, and they breathe out but through a narrow larynx. And it's a very short expiratory time so that they don't lose lung volume. So all sorts of things. CPAP is good, and you need plenty of it. And see, we don't know what they were doing. That's one of the problems.
Yeah, absolutely. So one thing we saw in the court case was that the collapses were always characterized as being sudden and unexpected. Um, so do you think that's a fair characterization, or do you think there were demonstrable medical reasons for several of these collapses?
A number of the cases I've read, the babies were really quite ill.
Hmm.
And an ill baby is very, particularly the more premature ones, likely to stop breathing at times. Um, but the cases, there's all slight difference, and we don't really know what was going on. And we do know, I mean, we've made lots of measurements that babies can be going on all right and then suddenly stop. And so it's called apnea of prematurity, and there are ways to treat that. One of the things is to give them more CPAP. Another thing which I never read in the Countess of Chester was to give them caffeine,
Hmm.
keeps them breathing.
I think some infants were given caffeine actually.
Well, yes, I didn't see. Yeah, I saw very little about the drugs that they were being given.
Yeah, I know at least one was given caffeine.
Good.
Yeah. But I don't, obviously I haven't seen the medical notes and I'm just going to what a neonatal nurse told me. But I know there's one infant that was given caffeine. How widely that was used, I don't know. But yeah. Um,
Yeah,
sorry, go on.
it's now very common. Babies who are not breathing very well, give them some caffeine.
Right. So you've touched on this in the previous answer, really, but well, actually, before we ask you this question, I want to talk about something else as well. So I think what happened a lot in court was that the prosecution, Dr. Evans, lent very heavily on the assertion that the infants were stable. Of course, there's a big difference between being stable and being, in the best of health. So do you think I mean, that to me was a significant factor because they just kept saying, oh, the baby was stable, then it collapsed. But in fact, the baby can be very ill and stable.
Well, I mean, I thought that comes back to where's this guy Dewey Evans been? I mean, we're seeing these babies and the reports of the cases. These babies were all ill in one form or another. Very rarely were they breathing quietly in air and normal. Well, I didn't see the blood gas results. It would have been interesting to see those because that shows how well whether the baby's breathing well or not. But just simply, I do not believe that these babies, the majority of them, were stable as I would consider it, with normal breathing, normal heart rate, normal oxygenation, and so on.
Hmm. So I want to ask you about monitoring on a neonatal unit because this is something that nurses have mentioned to me quite a lot. So this is very important, is it not? Could you speak about that a little, please?
Yes, well, I mean, I've been around a long time. We didn't used to have any monitors. And then they buy one monitor for the nursery and then try and move it around. And now every baby's got everything monitored, or at least should have.
Hmm.
They should be measuring heart rate, breathing, and oxygen saturation, at least. Um, and because if they're being ventilated, the ventilator nowadays, if it's a reasonably modern one, will be measuring how well the ventilation's going and even what the expired CO2 is. So if you don't monitor, and I'm a great believer, as I said before, we should be monitoring during resuscitation. If you don't monitor, then all you've got to go on is your observation, your guess. And people are very bad at that, at really getting it right. So that's why we need to monitor things so that they can see for themselves and be informed. So yeah, and they need to monitor properly.
So when they have what here we agree was a lack of experience and proficiency on the unit, do you think it's possible or even likely that the staff missed obvious clinical signs that more experienced units would have spotted?
Oh, well, it's quite possible. I mean, the babies who were on ventilators, I don't know what ventilators they were using, but the modern ventilators will be showing them all sorts of parameters about how well the ventilator's working and what the carbon dioxide level is and that sort of thing. And I know that some people find that very difficult to understand and would rather the numbers and the waves weren't there because they didn't have to think about them. But we need good monitoring. And of course, that means you have to educate the staff. And my thing is, yes, you can educate the young doctors, but you want to educate the nurses who are at the bedside because they're the ones who are looking after the babies and they get very good at it because they're doing it hour after hour, day after day. So, yes, we need good monitoring. And if they're not doing that, they ought to be. We need to know why.
Yeah. In accordance with that, I don't know if you know about the lack of ward rounds that were done on this unit. So they the consultants were only doing a couple of ward rounds a week, whereas nurses informed me it should be, two a day. Some that I've spoken to said we used to do three every day. So can that be a significant factor, and can that help? Can that have an influence on the lack of signs being spotted and so on?
I think it points to two things. One is the fact that the consultants thought that they could just do a ward round twice a week meant that they weren't really going to be very involved. And when I started in Portsmouth, the consultant said, I come round once a week, but ask sister, she'll tell you what's happening, she'll know what's happening. And they were very good at, knowing whether a baby's real or not, ever, or not. And now, you know, you can't really rely on the young doctors who've just started. I mean, the ones who've been there a couple of years would be very good at it, but and many of the nurses are relatively young, so the consultants do need to be keeping a good eye on it and going round twice a day if they can with the staff to hear what's happened in night duty and day duty. And if there's a sick baby, they ought to be there almost all the time, keeping an eye on it with the staff.
Yeah.
So I think the fact that they thought that they could only go in twice a week just showed they didn't understand what the whole problem was.
So do you think it's reasonable to describe that as negligent?
Uh, I think they were doing their best, but I think that wasn't what they should have been doing.
Hmm.
I mean, any in well, particularly for the sick babies. I mean, the others that are just growing and fattening up, it doesn't matter so much, and the nurses would be good. But any neonatal intensive care unit around the country would have at least two ward rounds a day and have somebody there most of the time.
Yeah. Okay. And can I also ask you how quickly babies can, if you don't spot the clinical signs, if you don't spot these subtle indications of problems, how quickly can babies deteriorate, neonates in particular?
Well, they can deteriorate very quickly, and that's why you need to be keeping a pretty close eye on them and recognizing that they're deteriorating. So I don't know that I could put a time to it, but you can't really take your eye off these sick babies.
Yeah,
And that's what the nurses are good at, you see. I mean, they'll soon come and tell you.
yeah, yeah.
And if they tell the young doctors, and the young doctors don't seem to take any notice, a good nurse will ring up the consultant, say, "Can you come and drop in? I think we got a problem here."
So
Yeah,
it's interesting that you say that because there is evidence that there wasn't great communication on the unit, that there was a bit, the culture, working culture wasn't fantastic. There's a bit of a divide, so that could be quite significant in itself.
it might be. And unfortunately, I'm afraid to say there are a number of neonatal units where they don't get on.
Yeah, yeah,
Human nature.
absolutely.
But that should be, it needs good management, good leadership. This is what we're doing and how we should be doing it.
Yeah. So just on the side, I've not, this just came to mind as we're talking, but I find it odd that you can have a neonatal unit without a neonatologist. So when I began studying this, I would have just thought automatically you have a neonatal unit, you must have a neonatologist. How is it possible? This is not even a level one unit, so it's a level two unit, but they don't have
Okay, well, this is history, really. I mean, when I started, we didn't have any neonatologists.
a. Hmm.
We just had, well, in fact, in the early days, the babies were mainly looked after by the obstetricians, who didn't know anything about them except how to deliver them.
Hmm.
And then they started appointing neonatologists, and there'd be quite a big unit like Bristol or Leeds or Edinburgh or something, who would appoint one neonatologist. Well, they couldn't be there 24 hours a day, 7 days a week, but at least they could teach people and get the culture organized. Now it's changed that most of these units would have a consultant in there living in at night time. And so what does that mean? It means you need more doctors, more consultants, costs more money. And sometimes the hospitals, the managers don't really understand, why do you need all these people?
Hmm.
Well, you want us to look after the babies properly, we need it.
Yeah. So I don't want to diminish the expertise or qualifications of a pediatrician, but do you think it's a significant disadvantage not to have a neonatologist on the unit?
Um, I think if you've got more than the occasional sick baby, you do need it. And the pediatricians have got more than enough to do. I mean, they're looking after every other childhood illness that comes in the door. And they're diabetics and asthmatics and all sorts of things. Um, so that's been their main focus. And because they keep them pretty busy and they hope that the babies are being looked after by the nurses and the young doctors. But see, unless they've got consultants there, then the young doctors don't get as much teaching and training as they ought to.
Hmm. So just to conclude, I mean, I already know what you're going to say to this question, but just to conclude this section of talking about care on the unit, do you think the treatment of infants on this unit was anywhere near the standard required for the acuity that they were dealing with?
No, I don't think it was. But we just got to remember we're going back to 2016.
Hmm.
You see, that's quite a long time ago now, and things have changed a lot. There's been a lot of tightening up and a lot more staff. I mean, when I worked in the first days in Cambridge, there were only three of us who were consultants, and we worked very hard. Now I forget what it is, they keep going up, but there's 13, I think, in order to cover all the different things and the clinics and transporting sick babies in and back and intensive care and people who are good at cardiac things and good at neurological things. And that's a big expense, but that's what it needs if you're going to look after the babies properly.
Yeah.
And the people say, well, it costs a lot of money. And I say, I tell you what, you just have one baby with cerebral palsy for the rest of its life. That costs a fortune. So it's well worth having the people to keep it well to start with.
Yeah, absolutely. So we're going to talk about child N now briefly. I'm only going to ask you one question about this because I think this case is extraordinary. But particularly, we have Dr. Sandy Bohin in court. So she references some period of crying as being hugely significant.
Yeah,
So
screaming, she says. Or it wasn't her, but that's what they
yeah,
said.
so she didn't witness it herself. This is all based on second-hand information, and then it comes from the parent. So obviously, the parent is hugely emotionally involved, firstly, and then secondly, the parent is not obviously medically qualified and may not have seen any other baby of this gestation previously. Very likely hasn't. So I was just wondering if you had a view on this because Bohin said she could tell, based on the parent's account of some crying, that the only possible explanation was malignant harm.
Well, that's nonsense. I can't I can't put it any kinder than that. I mean, babies cry all the time, and some of them cry very vigorously and very loudly, and depending on the situation. And yes, they made a great play here. Well, the baby was screaming. It must have been in terrible pain. Well, I think some of their pain is psychological rather than physical, and some babies cry more than others. I just I just do not think that anybody could, from a description, say that this is crying of induced harm.
Hmm. Good. I mean, I agree. I mean, I find that even by the standards of this court case, that was a fairly extraordinary claim. But the thing is, it just goes into court, and I mean, she was convicted. I mean, she is facing a life sentence on that case, really with very almost no evidence. This claim was central to it.
I think this case is a good example of the fact that they need a jury who understands neonatal care. They do that a bit for difficult financial things.
Hmm.
I think the jury here would have just been absolutely, not able to understand really what was going on with confident people telling them this is what's happening. The screaming was, you know, so I think we need a jury that understands, and I'm afraid to say lawyers who understand and can't be just moved along by rather independent pediatricians.
Hmm. Yeah. Of course, the other thing as well is it's 10 months. I mean, it must have been overwhelming for them. It seems to me that was a clear strategy of the prosecution was to make it last a really long time. To
Well,
make it seem like, oh, look at all the evidence we've got. We've been going on for 10 months.
yes, well, I think I don't know about lawyers at all. I would think they would try, and the judges and the court officials would try and keep down their time as much as possible, but they've got to go do their job properly.
Hmm.
Uh, so I think I'm not in a position to comment about that,
Hmm. Absolutely.
even though I think the yeah, it's highly specialized technical stuff, and it needs people who are assessing it to understand and not just rely on the experts entirely, because the experts might not be as expert as they like to tell you.
Absolutely. So we're going to talk now about the child K extubation case, where Lucy is alleged to have removed a tube from this infant. So I know that you have a view on what went wrong with this infant and the situation. So would you like to talk about that firstly?
Well, okay, just if we go into intubation, that is passing an endotracheal tube down into the trachea. One thing that I've not seen stated is where was it placed in the trachea? They ought to be able to see from an X-ray and it ought to be secured in such a way that it can't move. And it doesn't need to move very much because the trachea is fairly short in these tiny babies. So if we just say, well, they did put the tube in through the larynx, but it either moved or was only just below the larynx, then it's very easy for it to slip out. The other thing just to say is they need a good way of fixing the tube on to the baby's mouth or nose. And that's been difficult over the years because there's always a bit of dribble and so on. And, they try and tie it in, fix it in. Um, and that makes it then slip in and out very easily. And you don't need to slip in and out very much. You need the baby's head up, or you turn it over and the tube can move. Um, but we don't know. I've not seen anybody say where the tube was and before this happened. Perhaps it was just badly placed. Perhaps it was all right. We do not know. Then JRAM comes in and says, oh, golly, the baby's collapsed. And he takes the tube out and then has to re-intubate it. I mean, he should have been able to assess whether the tube was in the right place. A place like the Countess of Chester should have small little devices they put on the tube that measure carbon dioxide coming out. And if there is, then it's in the trachea. There was nothing that I've seen that they did that, but they might have done. So I just think, and of course, as we know now, he said, "Oh, I nearly caught her red-handed." Ah, but you didn't. I mean, you don't know that she was just because she was standing there, and as the neonatal nurses will tell you, if a baby's having an apneic episode, they're just told, well, just watch and see because most of the time they will recover. You don't want a bit like, them rushing in and doing things when it's not needed. You need to assess the situation. So I think JRAM overreacted in my way, didn't do the right things. And yeah, and
Mm.
to blame a nurse for dislodging the tube, that's just, I mean, maybe they dislodge the tube, but if they do, mainly it's accidental. They're moving the baby or something. But
So he's made this comment that he saw the tube had fallen out or whatever. It's not even properly established whether the tube fell out, I don't
no,
think.
no, it
But
wasn't.
but anyway, let's just assume for the sake of argument it did fall out. Um, he's made this extraordinary statement, oh, it could only have been a deliberate extubation.
Yeah,
So how can he possibly say that as a pediatrician?
he can obviously say that, but he shouldn't. I mean, because there are many reasons that tubes become loose and become dislodged. And, sometimes it's the staff moving the baby. I mean, if you pick up a baby, put it on an X-ray plate, you've got to be very careful you don't dislodge the tube. So I think, I mean, I'm frustrated by how confident some of these people's statements are when they shouldn't be.
Hmm. So we're going to ask you as well about the new cases in Liverpool, supposedly from 2012. Now, I know we haven't seen the notes for these, but we know a few details. We know some of the background information. The BBC have discussed it on Panorama. So, based on what we do know, do you think they have any merit whatsoever?
Well, I know very little because, just going through and keeping on top of all the other cases, and I thought, you know, I don't want to be involved in them dragging through hundreds of cases and trying to find what one's had its tube dislodged or whatever. So I've been waiting to see what happens. But um, I just come back to the thing I've said several times. Tube dislodgement is very common, particularly if it's not being secured properly. Um, and particularly in the tiny babies where there's very little room for maneuver.
Excuse me.
I,
Yeah,
I
absolutely.
don't think they're, I would be surprised if they'd be able to find any substantial evidence that means that somebody's done it. And of
Yeah,
course, one of the things that's frustrated me about the Countess of Chester, Lucy was on duty. Yeah, but was she actually caring for that baby? Well, sometimes she was, sometimes she wasn't. But just because you've got a chart that shows she's on duty doesn't mean to say that she's anywhere near the baby at that time.
yeah, and a lot of the time she wasn't. A lot of the time she wasn't a designated nurse.
Yes.
And also, there's so many instances in the case where Lucy basically responds to an emergency and
Yes.
raises the alarm.
Yeah.
Um, and that's essentially that's being held against her now,
Yes.
which is incredible, really.
I mean, she was, as far as I can understand by reading the stuff, she was very keen to do her best and help where she could.
Yeah,
And, they've held that against her, which is, they ganged up on her, I'm afraid to say.
yeah. I think we all agree with that. So just another little follow-on question regarding Liverpool. Um, Lucy's on a placement, obviously, at this hospital. So would basically just that you would expect her to be supervised at all times, wouldn't you?
Well, I think you'd have to ask the nurses about that,
Okay.
but I would imagine that student nurses would be well supervised, depending on how long they've been training and what was actually happening and the severity of the patients they were looking after. But yeah, that's what they're there to learn, and they should have supervisors.
Yes. So I'm going to ask you now about these multiple intubation attempts that we mentioned earlier. Could you explain some of the consequences of multiple intubations and the potential trauma?
Well, it's difficult. I mean, I have great sympathy with people, having spent half my life intubating babies. You're trying to look down a tiny hole and then find the right hole to put the endotracheal tube in. Um, they have steel laryngoscopes, and there's always a bit of tension, if not panic, about getting in the right place. And so, just to manipulate the laryngoscope and get the mouth and the larynx all in the right place is quite difficult. And if they don't get in, they go down the esophagus quite often, and that can be a problem, as they saw in the Countess of Chester. I think it was a year before a baby died because they got the tube down the esophagus and didn't recognize it. Um, and that's easy to recognize if you got the right things to do it with, basically measuring carbon dioxide coming out of the tube. So it really is a sign of being unskilled for the job. And that sounds like a criticism, but that's just how it is. The young doctors are in there, they're the ones, the consultants are only there 2 days, two ward rounds. Okay, they're in the hospital, but they're not there. So it's the young doctors get involved at the beginning, and they will not have had much experience of actually intubating a baby. I mean, they might have intubated mannequins, they might know the principles of what to do, but in the heat of the battle, it can be quite difficult.
Yeah. So I'm going to show you a video now on the neonatal unit that counts for Chester. This will just take a little bit of setting up. Just bear with me. So obviously, I know you've worked on numerous neonatal units. You're very familiar with them, but I wanted to show you the specifics of this one. So this is the actual neonatal unit at the Counter Chester. So let's just go back to here. So you can see, obviously, we have to watch an advert first. So we'll just bear with this until this goes through. Um, there's no other way of doing this, so I'm sure that's a fantastic series. You should look out for it. Yeah, here's another advert. Bear with me. Right, here we go. So you can see here. there's like windows, obviously, into all the neonatal units. And then you can see if you actually if you go through the tour, it's a very small unit. They're very all these units are very close together. And there's another bit later on, that I'll try and find what's here. Oh, here it is. Here it is. So here you see, this is where the nurses will be congregating. And then there's one nursery here. Then there's another nursery next door. This was a quite a cramped unit. Even people that work at the unit say that that is the case. Um, so considering that and considering what you know about how a neonatal unit works and your experience in the past, I mean, I looked at this and I looked through the whole video and I concluded that, um, you know, the logistical possibility of Lucy Letby conducting multiple attacks, well over 20 attacks, without, there's people coming in and out, there's doctors coming in and out, there's nurses coming in and out, there's parents coming in and out. There's in some of the for some of the nurseries, there's literally congregation areas right outside. There's windows going in from the corridors. The corridors are right next door. What is the logistical possibility that this could have occurred?
Rather low, except at night time, where it's not so busy and so on. I mean, I'm an old-fashioned guy. I used to like the nurseries which were all open.
Hmm.
So I could be standing at one end looking after a baby, and I could hear what they were saying down the other end, and I could see the monitors, and the monitors were causing trouble. I think all these little rooms the babies are in make it relatively difficult to communicate. And so, but probably they kept the doors open and you could shout from one person to another. But yeah, that's all what history was like. Um, Now the modern units are all much better organized.
Hmm. So it just, as well, some of the mechanisms are not easy to do necessarily. Um, it just seems to me you just every single attack is taking an extraordinary risk, and then she's supposedly done, and we know because we've seen all the nurses' statements from Thirlwall. So nearly 20 nurses have commented. Not one of them suspected a thing. Obviously, none of them saw anything. That they had no reason to believe that Lucy Letby had done anything wrong.
Well,
I think it would be incredible to have coordinated all these things in a cramped unit, surrounded by people, busy place, obviously. And you mentioned it might be more logistically possible at night, but of course, one of the comments that was made about her was she changed to day shifts and it supposedly continued. So quite a few of these supposed attacks happened during the day. I think it's nearly half of them even. So I just find that extraordinarily unlikely, from what I've heard from nurses as well.
yes, they're torturing the data to make it show what they want it to do. I think
Yeah.
is that you know I don't believe any of that really.
But I think the other thing as well is although they showed this video in court, so they did actually show this video in court, as far as I understand it. But when they were talking in court, a lot of the time they made it sound as if, oh, nurse, there was in nursery three, then she was in nursery four.
Yes.
Nursery two and nursery three, like right next to each other, literally. And even nursery one's only like through a door. It's only a few
Yeah.
yards away.
Yes.
They're all on top of each other, basically. But I think they gave a very false impression, like, oh, people were coming in and out and they're all over the hospital, when really this is a very small unit, actually. So I just wanted to show you that and get your thoughts. Um, so just a couple of questions to go. So the first one, I just wanted to ask you about you mentioned that you were asked to be on the expert panel. So I just wondered how you feel about their work and the conclusions that they've drawn.
I think they did a great job, but they had the advantage that you and I haven't had is that they saw the notes.
Hmm.
And you know, I know quite a lot of the people on that panel, and they're all very experienced and capable neonatologists. So I say that because that means I would believe what their assessment was. Um, I think Julie did a great job getting those people and persuading them to do it de bono, give up their time. But yeah, and I think, I mean, obviously the full report is got to have a lot more information in it. It's a pity that we can't see it. Have you seen the full report?
No, I'm not
No.
that privileged, unfortunately.
They've been very careful for it not to get out into the public domain because they're just a bit worried that it's going to, all sorts of people will be saying things and it'll upset the CCCR, whatever they are, the Criminal Cases Review Committee.
Yeah,
Uh, but I think it was a good idea
yeah.
because at least now people can say, well, these cases have been gone through by expert neonatologists, and this is their opinion.
And is it fair to say that the expert panel far outranks experts that appeared in court?
I think Dewey Evans wouldn't be good enough to serve them a cup of tea. I mean, you can't compare. I mean, he's not an expert neonatologist. He might have opinions, but he's not doing or saying the right things. So, I mean, that's one of the problems of this trial, as we know. There was no experts called for the defence.
Yeah. So it's interesting what you mentioned about Dr. or Professor Lee assembling all these people. So that really backs up what you said earlier that they would help. Neonatologists would help in court cases, and other professionals, no doubt, would help as well. So there has to be a way of getting better experts into court cases so that the jury hears better evidence and better decisions are made. Or ideally, in a case such as this, it doesn't go to court in the first place. I feel like there has to be a solution because these professional people who do care about these things. I think not just about the outcome of the court case, that's important, obviously, but about patient safety and care in the NHS.
Yes, I think there's going to be a lot of discussion after this about how do you choose experts and who are experts. Um, and I think it's right that the British Paediatric Association and the British Perinatal Group should be coming up with some idea who are the experts and actually have a panel of people who can be chosen to or asked to go and do it. The problem is all these people, I mean, you take Nina Modi, been president of the college and done, she's busy, busy, busy. So to be asked to go and take on these cases and possibly go to court is enough to make anybody shrink under the desk and hide.
Mhm, absolutely.
They're a lot of work.
Yeah, I mean, there has to be something done, in my view, to create a panel or, guarantee them pay or something. Um, I don't know what could be done exactly, but there can't be this competition to just see, right, we'll get the best experts we can, or we've got a few. How many of you got none? Or well, never mind, we'll just carry on anyway.
Yeah,
I mean,
yes.
that's just disastrous.
Well, you can pay them. I'm all for that. None
Hmm.
of these people will be starving.
Hmm.
And I guess everybody likes a bit of money. In fact, we tried to calculate what Dewey Evans is earned during the course of these trials, probably not much short of 1 million. Even if it's half a million, it's still a lot of
A lot.
money. And that does encourage people to put their hand up. I mean, he didn't leave pediatrics and become a professional expert if it didn't earn him more money. But yeah, I think it's tricky. It's tricky for everybody, not just pediatrics, medicine, engineers, whatever, finance people. And I'll talk to my friend Michael about. Well, I have asked him before, what's an expert? And he says somebody who tells you they're an expert, which doesn't encourage me very much.
Not hugely encouraging, I would
Uh,
agree. So my last final question is just, what is your overall view of the Lucy Letby case at this point in time?
Well, as I've really said at the beginning, I came to the conclusion that this looks like not a miscarriage of justice, and for this poor woman to be in prison for the rest of her life, and even if the CRC goes on like they have done, she probably won't be let out for 10 years, by which time she'll be 45 or something. I mean, it needs a better system of assessing these things. I mean, I hold the view that why don't they just let her out on
Hmm.
or not keep her in prison? I mean, she's not the sort of person who's going to go around murdering people. Um,
Well, there has been opined that she should be out on house arrest
yes,
if when a CCRC refers it to the Court of Appeal. Now, I'm skeptical that will happen because, you know, people don't like to make decisions, do they? So that's my experience.
yes.
So
Well,
I don't know if it would happen, but it should happen morally and ethically. I agree.
well, particularly with, uh, I suppose they just say, look, she's murdered all these babies. She's the most notorious killer of babies in the world. You can't just let her run free. You've no idea what she might get up to.
Yeah, I mean, being kept under house arrest, though. I mean, what's his name was kept under house arrest? The South African athlete. I've forgotten his
Oh,
name now.
yes, yes, with one leg or no legs or
Yeah,
something.
yeah, that's the one.
Um,
Pretorius, is that his name? Oscar Pretorius, is that correct?
yes, Oscar, I think you're right, Pretorius or
Something like
something like
that, anyway.
that. I'm hopeless at names these
Yeah.
days.
So he was kept under house arrest for quite a long time.
Can
Uh,
I ask you a question? Oh, golly, I've got
okay,
a meeting at 3 o'clock.
far
Um,
away.
what's your background?
Oh, so I have been a freelance writer for about 12 years now, I think.
Yeah, okay.
So I wrote over the last kind of 6 to 7 years, I concentrate on ghostwriting. So I've ghostwritten many books during that period, written and edited about 50. So all I was doing before the Lucy Letby case was ghostwriting, and I would have been writing another book, and I just heard about, I would have gone, I literally went down to the kitchen to get some food and just heard about this on the radio, and I just listened, first of all, shocked that this had occurred, and I just started to listen to it, and I must have decent intuition because I just started to think, what, she poisoned people with milk? What? That just didn't ring true to me at all, and I'd never heard of a case like this where there's so many infants and so many different murder methods, supposedly. And I just started to think, well, I haven't heard any evidence for this at all. So then a bit more time would pass. And then I thought, right, well, I'm going to look it up for myself. And then I started to look into it and I saw the so-called confession note. And I was like, come on, I mean, this is ridiculous. This is never a confession note. And then I just became, I thought, right, well, I'm going to look up more stuff. And the more I looked at it, the more it looked like a miscarriage of justice. And then I just felt, well, if this has really happened, this is horrendous. I wonder if I could do anything to help. So then it just kind of snowballed from there. And
Well, I mean,
I guess,
from my point of view, you have put in an immense amount of work, physical work and brain power, and keeping up to date with all these things. Uh, I think you deserve a big prize for that. It's hard work, isn't it?
yeah, yeah, it is. I mean, thank you for saying that. I really appreciate that. Means a lot. Yeah, I've worked really hard on this. This is my life now, basically. Because the thing is, people don't see as well that I'm doing campaigning stuff all the time and following leads and communicating with people. And like today, I managed to catch up my emails.
Yeah.
I had about 30 unanswered emails today, so I caught up with them. So yeah, I mean, all I wanted to do when I first heard about this was to help and to, can I know I have certain skills and abilities. Can I use them to help? And now I'm in a position where I can do that. So now that I am in a position where I can do that, I'm not going to waste that. opportunity, I'm just going to give everything that I can to
Yeah,
help.
well, you're doing a good job. I must love you and leave you because I've got to be in the middle
Fabulous.
of Cambridge in 15 minutes, and it
But
takes me at least 20 minutes to get there.
no worries. Thank you for giving me so much time. We're really appreciative.
So
And
that's right. Very nice to meet you and talk to you, and the best of luck with you.
thank
And
you. I'll speak to
I'll
you
help
again
what
soon.
I can.
Enjoy,
But I
enjoy.
think they've decided I'm too old and doddery and not.
Well, you've been
Yeah.
absolutely brilliant today. So thanks so much for your time and have a good trip. And I'll speak to you again soon.
Okay. Yeah. Keep going. Bye.
Thank you. Bye now.